Hi everyone, my name is Kataoka from National Cerebral and Cardiovascular Center, Suita, Japan. Let me start my presentation about LDL-C below 55 and cardiac outcomes at non-culprit lipid-rich plaques. This is my COI. Near-infrared spectroscopy imaging is an intravascular imaging modality to visualize lipid-rich plaque. Recent observational studies have demonstrated that NIRS-derived max LCBI above 400 predicted future coronary events. However, the best way to manage these kinds of patients is not established yet. ESC guideline recommends LDL-C below 55 in very high-risk subjects. Here is a representative case with massive yellow signals at non-culprit sites. However, achieving LDL-C below 55 could improve this kind of patients remains unknown. The REASSURE-NIRS registry is an ongoing multi-center registry in Japan. This registry enrolled over 1,000 patients receiving PCI, and then we selected 726 patients with a variable non-culprit lesions. These patients were stratified according to the max LCBI at non-culprit lesion below and above 400. In this analysis, we looked at all of non-culprit lesions with percent diameter stenosis above 20%. We set primary outcome as a composite of CV death and non-fatal MI, and secondary outcome was defined as a composite of CV death, non-fatal MI, and unplanned revascularization. Firstly, we looked at patients with max LCBI below 400. Patients with on-treatment LDL-C below 55 was older, and they had more ACS with a lower frequency of dyslipidemia. In terms of the lipid-lowering therapies, patients with LDL-C below 55 were frequently received high-intensity statin, and their on-treatment LDL-C level was 45 mg per deciliter. Here's the data about the primary outcome in patients with max LCBI below 400. There was no significant difference in the cardiac cause death and non-fatal MI between patients with and without LDL-C below 55, and p-value was 0.177. And then we focus on patients with max LCBI above 400. In patients with LDL-C below 55, they were less likely to be female, and they less likely have dyslipidemia. With regard to the lipid-lowering therapies, patients with LDL-C below 55 more likely received high-intensity statin, and their on-treated LDL-C level was 44 mg per deciliter. Here's the main data from our registry. In patients with max LCBI above 400, achieving LDL-C below 55 was associated with a lower frequency of CV death and non-fatal MI, and adjusted hazard rate was 0.89 and p-value was 0.042. When we look at secondary outcomes, similarly, achieving LDL-C below 55 was beneficial for the CV death, non-fatal MI, and unplanned revascularization, and adjusted hazard ratio was 0.71 and p-value was 0.026. We further looked at the efficacy of achieving LDL-C below 55 in ACS and stable CAD patients, respectively. As shown here, achieving LDL-C below 55 was more beneficial, especially in ACS patients, rather than stable CAD patients. Here's our conclusions. Achieving LDL-C below 55 was associated with a lower cardiac events risk in patients with lipid-rich plaque. Our findings suggest that patients with non-culprit lipid-rich plaque could benefit from lowering LDL-C below 55, and intravascular imaging guided risk stratification may help to select lipid management with appropriate intensity in the secondary prevention settings.
Thank you for giving me the opportunity to have this presentation entitled Challenge to Monotonic Relationship between the LDL cholesterol and cardiovascular event. Is the lower the better true? We hypothesize that the LDL cholesterol level that should be targeted for Japanese CAD patients to reduce cardiovascular events would be higher than that for Western patients, and that there would be an optimal target of LDL cholesterol, a threshold value below which it does not affect the incidence of cardiovascular events. To test our hypothesis, we perform a sub-analysis or real CAD study to explore such an optimal LDL cholesterol level in Japanese CAD patients. This is a real CAD study to determine whether the high dose as compared with low dose pitavastatin therapy within the approved dose range could reduce CV events in Japanese patients with stable CAD. This is a Kaplan-Meier curve for the primary endpoint. High-dose pitavastatin significantly reduced the primary endpoint compared with low-dose pitavastatin. This is a flowchart of patients enrolled. We combine two randomized groups into one and perform the analysis on the total data. Our purpose was to investigate the association between each endpoint, the primary endpoint of real CAD trial, cardiovascular death, myocardial infarction, ischemic stroke, hemorrhagic stroke, and achieved LDL cholesterol level. We set the threshold value of LDL cholesterol level under which the hazards were assumed to be constant by including an artificial covariate max in the Cox model. We named this model the bottoming out model. The analysis was repeated with the different LDL cholesterol thresholds every 10 mg per deciliter from 40 to 100, and the model fit was assessed by log likelihood. We divided the 11,105 patients into 6 categories by the LDL cholesterol level at 6 months and calculated event rate and multivariable adjusted hazard ratio among each category. When the category LDL cholesterol 100 to 125 was used as a reference based on Japanese guidelines, the event rate and adjusted hazard ratio was the lowest in the category of LDL cholesterol 50 to 75 for the primary composite outcome and myocardial infarction, but not LDL cholesterol less than 50. Next, to explore the optimal target of LDL cholesterol, we assume a threshold value below which the incidence of cardiovascular event is not further lower, and then calculate the multivariable adjusted hazard ratio for each of the threshold values set by every 10 mg per deciliter. For primary composite outcome, the model fit assessed by log likelihood was best when the threshold LDL cholesterol value of 70 mg per deciliter was assumed. This figure indicates the concept of this model for the primary composite outcome, where the horizontal axis shows LDL cholesterol and the vertical axis adjusted 5-year risk. In the red line, where the threshold LDL cholesterol is assumed to be 0, the monotonic relationship is established, representing the lower the better. However, it is not possible in reality. In the other lines, where the threshold LDL cholesterol is assumed to be 40 for the green line, 70 for black line, 100 for the blue line, there are inflection points, and the monotonic relationship is not established in the part where LDL cholesterol is lower than the inflection point. The black line demonstrates that the best model fit by log likelihood. The black line indicates that when LDL cholesterol is lower below 70 mg per deciliter, the risk of cardiovascular events is constant, and when it is above 70 mg per deciliter, the risk increases as LDL cholesterol rises. Conclusion. A threshold value of LDL cholesterol appears to exist when statins are given for the secondary prevention for cardiovascular event in Japanese CAD patients, and this threshold might be 70 mg per deciliter for primary composite outcome. This result might provide a new lipid-lowering strategy for the secondary prevention of CAD in Japan, treat to target to 70 mg per deciliter and thereafter fire and forget. Thank you for your attention.